This is the AC crossover test, and if you're suspecting some AC joint pathology, there are a couple of tests that you could do to implicate the AC joint, and this is one of them. So all you're going to do is have the patient's arm flex to about 90 degrees, and you're going to forcibly bring them into full horizontal adduction. So you're trying to shut down or impinge on the AC joint. You're looking for reproduction of their anterior complaints. And things that might cue you into the AC joint being the problem would be those anterior complaints of pain. And a patient who maybe they feel fine, and as they're bringing their arm into abduction, and they get a little bit of that impingement at the last bit of abduction, so somewhere between 160 and 180 degrees of abduction. So it's positive if you get pain in the AC joint, but it's not positive if it's painful in the posterior aspect of the shoulder. This is the AC shear test, which is another test you can do to test the AC joint as a possible source of shoulder complaints. So you're basically going to cup your hands around the deltoid. So one hand is going on the posterior deltoid, then come around the spine of the scapula, and the other hand is on the anterior deltoid coming around the middle part of the clavicle. So all you're going to do is basically push both ways to create that shear at the AC joint. And a positive finding would be the reproduction of the patient's anterior complaints of pain. This is the Paxino sign, which is another test you can do to test the AC joint. So all you're going to do is put your thumb on the posterior aspect of the acromion, and then your index and middle finger would go over the middle part of the clavicle. And all you're going to do is basically pinch together, again, to create a bit of a shear. And if you have a larger patient and you have smaller hands, you could use one hand on each side, but most of the time you could just use the one hand. So a positive finding would be the reproduction of those anterior complaints of pain. This is the external rotation lag sign, which is a test for a suspected rotator cuff problem, specifically a test for the infraspinatus or supraspinatus. So you're going to passively bring the patient's arm up into about 90 degrees of abduction, bring them into external rotation, and then tell them before you do it that you're going to move your hand away and that you want them to hold their hand still. If they cannot maintain that and their arm begins to lag or drop down, then that would be considered a positive finding. This is the internal rotation lag sign, which is another test you can do for suspected rotator cuff pathology. So you're going to passively bring the patient into internal rotation with their hand behind their back and passively lift their arm away from their trunk. You tell them to hold their hand there and that you're going to move your hand away. And if the patient can't hold their hand there, then that would be considered a positive test. So this test implicates more of the subscapularis as the involved part of the rotator cuff. This is the Hornblower sign, which is another test you can do for a suspected rotator cuff problem. And this test emphasizes teres minor. So what you're going to do with this test is you're going to bring the patient into about 90 degrees of scaption, so in the plane of the scapula, and then into external rotation, and then resist external rotation from this position. And if they can't resist that, or it reproduces their pain, or if they were significantly weak, then that would be considered a positive finding. This is the belly press test, which is a test you can do for suspected rotator cuff pathology. It's a test for the subscapularis, and you're going to take your hand and rest it against the patient's hand on their belly. And the cue that you can provide to your patient is you can tell them, what I want you to do is you're going to keep your arm still and just push right into your stomach. And what you're looking for here is that they can generate the tension. So it is positive if they are unable to keep the pressure on their belly without extending the shoulder or flexing the wrist. So you can either do this in standing or sitting. So again, if you didn't have good strength for internal rotation, you would probably compensate by either extending your whole shoulder back, so that's how you can still push into your belly, or you would flex your wrist. So it would look like you would push into your belly, but it's not coming from your shoulder internal rotation, and that would be considered a positive test. This is the drop arm Codman test, also known as arm dropping test, and this is a test you can do for suspected rotator cuff pathology. And with this test, it's really important you passively bring the patient into shoulder abduction to about 90 degrees, and then you should also rest your hand over the spine of the scapula because you don't want them to assist with any hiking of their shoulder. So tell them to let their arm just relax, and you're going to bring them up. Make sure you're going to tell your patient before you move your hand away. So you tell them, I'm going to slowly move my hand, and I want you to leave your arm right at the side and hold it there. And once you let go and they're able to hold that, now you tell them, now very slowly and controlled, lower your arm back down to your side. And she can do it, so she has an intact rotator cuff. But the two things that would make this a positive test would be if you bring her up and you can't even remove your hand and she can't hold that herself, or she's holding it and she's struggling, and when she starts to lower, she collapses. Both of those ways, it would be considered a positive finding. This is the drop sign, or also known as dropping sign, and this is another test you can do for suspected rotator cuff pathology. So you're going to have the patient resting with their arm at their side, and you're going to bring them into about 45 degrees or so of external rotation, and then have them isometrically externally rotate against your resistance. So it would be considered a positive test if they drop out of that external rotation or can't maintain that. So if the arm drops, back to neutral, and that's going to be more specifically for an infraspinatus problem. This is the SPEEDS test. It's one of the tests you can do for suspected bicipital tendon pathology. And all you're going to do with this is you're going to have the patient come up to 90 degrees of flexion, palm all the way up, and you're going to resist flexion at the wrist. And typically, if someone has a bicipital tendon problem, that'll be painful and they'll complain of some of their pain. You then turn them so that the palm is facing down, repeat the test, and if this actually feels better than when the palm is up, that would be considered a positive test for the bicipital tendon. So this is a test for bicipital tendinopathy as well as a superior labral tear, and again, it's positive if it reproduces tenderness or pain in the bicipital groove. So this is the Yergason's test, which is another bicipital test that you can do. So this is a nice test, especially if you're concerned about the integrity of the transverse ligament or if the long head of the biceps is possibly subluxing as the patient moves. So you could rest your fingers over the long head of the biceps, and then we start in the position with the forearm pronated. And then what you want to do is you're going to tell the patient to gradually turn their palm up and twist out at the same time while you resist them. So go ahead, try to do that. And what you're feeling for is maybe getting a feeling of their pain there, but mostly you would feel a popping or possibly subluxing of the long head of the biceps. So again, this is a test for the integrity of the transverse humeral ligament, and so the examiner resists supination of the upper extremity, and you can palpate the long head of the biceps to see if it moves out of the bicipital groove. So this is the posterior glide at the glenohumeral joint. So for the posterior glide, you're going to have the patient lying supine, and you want to have them in an open pack position. So that's abduction, a little bit of flexion, and remember that the glenoid is angled, so I'm going to get the heel of my hand over the head of the humerus, and with the other hand gently grasp the distal end of the humerus. So you let your arm relax, and then you're going to press down and do the different grades depending on what the patient needs. So if you want to do for pain modulation, you find R1 and just go short of that. So that's grade 1. And then grade 2 is a larger amplitude. And if you want to work on stiffness, you can go a bit deeper and have a larger amplitude. So again, from this position, you're going to glide the humerus posteriorly at the glenohumeral joint, parallel to the AP plane of the glenoid fossa. This is the inferior glide of the glenohumeral joint. So again, you're going to have the patient supine, and then with one hand, you're going to gently grasp proximal to the patient's elbow, and the other hand, the mobilization hand, is going to be providing that inferior glide at the glenohumeral joint, so parallel to the superior inferior plane of the glenoid fossa. So you want to make sure that your arm is lined up correctly so you can have the proper line of force to create that inferior glide. And again, depending on the patient's needs, you can provide the different grades here. This is the lateral glide at the glenohumeral joint. So you're going to again have the patient supine, and then you're going to hold the patient's arm with one hand just proximal to the elbow and the other hand in the axilla so you can create that lateral distraction and that lateral glide. So you must be careful to apply that lateral distraction with a flat hand because sometimes the tendency in applying that force is to turn that hand so that the distraction applied is to the side of your fingers, which is uncomfortable for the patient. So you want to make sure that you are having a proper line of force. So you're going to bring their arm around you, so use your body to your advantage. And by doing this, you don't have to do too much with your arms. So you go inside the arm, so in between the arm and the trunk, and wrap their arm in front of you, and then use your body to create that lateral glide. This is a quadrant grade 2 row the boat. So this is not in the cardinal plane. This is a quadrant mode. So grade 1 and 2 is called row the boat. So what you're going to do, say she's saying when she gets to here that pinches her and she's got that subacromial pain. So you're going to bring her out of what's hurting her. So you find her barrier and then take her out of it and then work short of it. So you want to stand close and don't stand way out to try to row the boat because she won't relax. So you give her a hard backstop. So you get your stomach out by her. So you put the arm short of the barrier and then begin to row the boat and make that large amplitude so that it is a grade 2. So you would do this in bouts of 30 seconds. And this is a great way to modulate pain. So after you've worked on other stuff with the patient and worked on stiffness, this is how you can finish your treatment. So with a grade 2, row the boat. This is the quadrant grade 3 flop the fish. So if I wanted to do a quadrant for motion or stiffness, then you're going into grade 3s and 4. And so I'm going to do the grade 3. So now what I'm going to do is I usually start by doing these because most people can't get all the way back into their arm in abduction over their head because they're too stiff. So you can also use a pillow or a towel to stop their range just a bit. So say you bring her up to here and now you need to work on stiffness. So then I'll come out of that a little bit because I don't want to be against her barrier. And now because I'm working on stiffness, it's a grade 3. So again, here I'll use the towel. And now we are going to flop the fish. So it's more of ulnar deviation, and you're going to tuck your elbows at your side and then flop the fish. So while you're doing this, you want to make sure you're going into a rhythm as well.